is diabetes mellitus. And the first among them is what is the classification and pathogenesis of diabetes. So let's talk about this in the remaining minutes of time. Let's move on. See there. Now, what is diabetes? If somebody asks you what is diabetes mellitus, everybody know how to answer. So this is the proper way of defining diabetes. Diabetes mellitus is a clinical syndrome characterized by hyperglycemia, which is caused by absolute or relative deficiency of insulin. This is an excellent definition because all cases of diabetes will have hyperglycemia, first thing. But what is the cause of this hyperglycemia? Isn't it? What is the cause? That is either because of absolute deficiency of insulin or relative deficiency of insulin. Absolute or relative. Okay. Anybody? What is relative deficiency?
Sir, in the insulin are there, sir, but it's not sensitive to the receptors of.
Good. Very good point you have mentioned. Insulin is there, okay, but it is not, responding. Receptors are not responding to that insulin. This is known as relative deficiency. Or another one, there is a high demand of insulin, okay, because of peripheral resistance, but the amount of insulin may not be enough. This is also known as relative deficiency. So absolute deficiency of insulin occurs in type 1 diabetes and relative deficiency of insulin occurs in type 2 diabetes. So both things are included in your definition. Diabetes is usually irreversible, and although patient can have a reasonably normal lifestyle, its late complication results in reduced life expectancy and major health cost. So please, mute yourself. So let's, elaborate this important point here. Diabetes is usually irreversible condition. Once it develops and once we have diagnosed it and once we have started the treatment, the treatment will continue for probably remaining period of life. I'm not denying we can stop the treatment if the patient are doing very well. We can, but the chances of that is very less. So just remember that, a type of practical information. Once you start treating diabetes after the proper diagnosis, the treatment will continue for the rest of the life. Another point, diabetic individual can have a reasonably normal lifestyle, reasonably normal, if they keep that blood sugar level, okay, tight control of blood sugar level. Probably they'll postpone this complication much later in their life, or sometimes they do not develop that complication also. It is all about how tightly you are controlling the blood sugar. But if somebody is negligent, they do not even check what is their blood sugar level after the diagnosis, then the complications will arise quite early in them. And those complications are, okay, microvascular complication and macrovascular complication. One of the important macrovascular complication is atherosclerosis. Never forget this. Diabetes mellitus is an important risk factor for atherosclerosis. Whereas microvascular complication, the major one are retinopathy, nephropathy, and the neuropathy. So these are very big problem in a diabetic patient. Let's move on. The same thing is written here, but still let us go through them. These complication or late complication of diabetes include macrovascular disease leading to increased prevalence of coronary artery disease, peripheral vascular disease, and stroke. All of these are related with atherosclerosis, and microvascular disease or damage causing retinopathy, nephropathy, and neuropathy. Let's move on. Now, before we discuss the pathological aspect, we always talk a bit of physiology. Now, let's talk about the physiology or the structure of insulin. What is the action or effect of the insulin in our body? How this insulin is secreted and from where it is secreted. Okay, so let's focus on this type of discussion. Now, insulin is a hormone. This insulin is secreted by pancreas, the endocrine part of the pancreas, which is known as islet of Langerhans. And inside the islet of Langerhans, there are beta cells. These beta cells are secreting the insulin. Okay, this is very important point, and every student know this already. Insulin is coded for on chromosome number 11. So the gene which is responsible for coding the insulin is on chromosome 11. After insulin is secreted, the insulin enters the portal circulation. Of course, pancreas, okay, the venous drainage of the pancreas goes to the portal vein, and through that it will carry to the liver. And liver is its primary target organ. Okay, about 50% of the secreted insulin from the beta cell is extracted and degraded in the liver, and the remaining 50% will only be active. So this is a small, physiological aspect. Let's move on. See this. This is a very important slide. All of you, please focus here. Here, this is the pancreas gland. The pancreas is a long gland which has got head, neck, body, and tail. This is the head of the pancreas. This narrow area is the neck of the pancreas. This is the body of the pancreas. And here is the tail of the pancreas. So head of the pancreas is lodged on the concavity of the duodenum. Duodenum is a C-shaped organ. It's the first part of our intestine. Now, on the second part of the duodenum, see there, okay? On the second part of the duodenum, the common bile duct is opening, and even the pancreatic duct opens there. Now, we are not concerned about this aspect of the pancreas or duodenum because this is an exocrine part of the pancreas. The endocrine part of the pancreas is known as islet of Langerhans, and this is distributed throughout the pancreas gland here and there. And beta cells are the most important cells of islet of Langerhans, which are, responsible for the release of insulin. So these are the beta cells which are shown here. Okay, it is very nicely supplied by blood vessels. So this hormone is directly released into the blood circulation. That's why they are called hormone. Hormones are directly released into the blood circulation. So after that, it will enter in the portal circulation and enter the liver. Now let's come here. This C. When insulin is released, this insulin is released as a proinsulin first. Proinsulin. Now this proinsulin is degraded, okay, to release insulin as well as C peptide. This is C peptide. Now see here very carefully. This is a bigger molecule which is known as proinsulin. This blue part is the insulin, and this red part is called C peptide. C is a connecting peptide. This connecting peptide, okay, is the inactive or inert substance, but it has got a very important clinical role here. What is that clinical role C peptide has? Anybody?
to, to assess the endogenous release of insulin.
Excellent. Excellent answer. To assess the endogenous release of insulin, C peptide gives us a very, very important, concept. For example, if C peptide is there, when we evaluate it, that means insulin is secreted by the beta cell. When we give insulin from outside, there is no C peptide found in the serum or blood. Never forget this. This can be utilized as an important question for you later on. Now, this is the basal secretion of insulin, okay? And this is the second phase of insulin secretion. The first phase is the acute phase, we say. It is in response to the elevation of the blood sugar level. And second phase is a sustained release of the insulin because of the other, nutrients, or when the blood sugar is relatively decreased in the blood, it still gets a bit of stimulation. So this causes, sustained or second phase of release. Now let's move on. Now, all of you, please focus on this slide. This slide is telling us about the insulin secretion from beta cell. Okay, now let's talk about how insulin is secreted from the beta cells. So before that mechanism, we should know what are the important, things here. Means important structure which are present on the cell membrane. Now see there is a GLUT2 transporter whose function is transporting glucose from outside to the inside of beta cell, and it doesn't need the help of anything. Means glucose can easily pass through it. Another is ATP sensitive potassium channel. There is sulfonylurea receptor, which is quite adjacent to it. There is a calcium channel, and these are the vesicle which has insulin inside. Okay, and this is the cell membrane. Now, what happens here? When glucose is increased in the blood, means after taking a good carbohydrate meal, there will be hyperglycemia. So glucose is present there. That glucose will enter into the beta cell through GLUT2 receptor transporter. Now, this glucose will be metabolized. Remember the different, metabolism or metabolic cycle for the glucose, like Krebs cycle, isn't it? You have already studied that in biochemistry. Okay, glycolysis and Krebs cycle. So after Krebs cycle and after that type of mechanism, there is synthesis of ATP. This ATP is essential here. This ATP will act on ATP sensitive potassium channel which is present there and will close it. See there is a closure of the ATP sensitive potassium channel. Now, after it is closed, there will be depolarization of the membrane. Now, in this case, this is the way of membrane depolarization, but in other type of cells, there is another way which is mentioned in different textbook. We have already studied that before. That is entry of sodium inside the cell will also depolarize the membrane. Okay. Now, after the membrane is depolarized, what will happen now? The calcium channel will be activated or opened. Then calcium will enter into the cell. This calcium influx will lead to migration of this vesicle, which are having insulin inside, and then it attached with the cell membrane. Then there is exocytosis of the insulin outside. This is the mechanism. Now, one more thing here, the sulfonylurea receptor. See this, sulfonylurea is a type of oral hypoglycemic drug. Okay, oral uh, anti-diabetic drug, that is a better term. So it will bind to its own receptor, and after that, okay, it will activate the ATP sensitive potassium channel. Now this potassium channel is again closed. There will be membrane depolarization, and all the mechanisms are similar, and ultimately there will be release of the insulin. That's why if we give sulfonylurea in type 2 diabetes for a long time, what will happen now? The person will become, the person will gain weight because of the effect of this insulin release. Insulin is anabolic hormone, so if it keep on releasing, then it will lead to weight gain. And another important question which is asked in the exam, because of this effect of the insulin, there will be hypoglycemia. So hypoglycemia can be important side effect of sulfonylurea drug. Okay, so let's move further. Let's move on. Now let's talk about the different type of glucose transporter. So what are these, and what are their function, and where are they present? This glucose transporter are the family of specialized, okay, glucose transporter protein, and they carry glucose through the membrane into the cell. So they are a type of transporter protein which are present right there on the cell membrane, and through them glucose is entering into the cell. Now the important type of glucose transport. There's so many different types, okay? But these are the important types of glucose transporter. They are GLUT1, GLUT2, GLUT3, and GLUT4. Now, where are they present and what are their function? GLUT1 enable basal non-insulin stimulated glucose uptake into the many cells. Non-insulin stimulated glucose uptake means we don't need insulin for the entry of glucose into the cell, okay, through GLUT1. One important concept I like to provide you quickly here: when we do exercise, when we do physical exercise like running or working in the gym, those type of things, our muscle will uptake will uptake glucose without any insulin. We don't need any insulin for the entry of glucose into the cells during that time. So this will explain the situation here. GLUT2 transport glucose into the beta cell. This is a prerequisite for glucose sensing. Without glucose entering into the beta cell, remember, insulin is not going to be secreted. So this is the function of GLUT2. GLUT3 enable non-insulin mediated glucose uptake into brain and placenta. So these are special type of transporter present in brain and placenta. And GLUT4 is the majority of them which enable much of the peripheral action of insulin. So these need insulin for the uptake of glucose. And they are predominantly present in the fatty cells and the muscle cell. Sometimes when we are not working, when we are not doing exercise, still our muscles need the entry of glucose. During that time, we need insulin. So this is the very important concept. Let's move on. Now, let's talk about the insulin receptor. Okay, and what is the function of this insulin receptor? Now, this insulin receptor is a glycoprotein which is coded for on the short arm of chromosome number 19. It is the gene is present in the chromosome 19. Remember, the gene which is responsible for the release of secretion of insulin or synthesis of insulin is in chromosome number 11. But for the insulin receptor, okay, it is chromosome number 19. It has got two alpha subunit which include the binding site for insulin and two beta subunit which traverse the cell membrane. So we have got a structure there. Let me explain this first and then I'll show you that structure. When insulin binds to the alpha subunit, it induces a conformational change in the beta subunit which results in activation of tyrosine kinase. And that mechanism leads to migration of the GLUT4 glucose transporter to the cell surface and increased transport of glucose into the cell. Now, let me make it easy for you. When insulin is attaching on its receptor, then only the GLUT4 transporter is binding to the cell surface, and that GLUT4 transporter is responsible for entry of glucose into the cell. If insulin is not binding, there is no entry of glucose into the cell through GLUT4 transporter. This is very, very important concept. So what does that mean? Enough glucose is present in the blood, but our cells cannot uptake that glucose into the cell because of lack of insulin through GLUT4 transporter. The insulin receptor complex is then internalized by the cell. Insulin is degraded there and the receptor is recycled to the cell surface. So this is the end process, isn't it? After the insulin is bound, after the insulin has already done its job, that is, glucose has entered into the cell. What happens to that complex now? It is taken inside, insulin is degraded, and the receptor is recycled back to the cell surface. Now let's understand this with the help of a picture. Now see this? It will make it very easy for you. So this is the cell. There is the cell membrane. So see this is the insulin receptor we have. See here, this is insulin receptor. These are the alpha subunit and these are the beta subunit. Two alpha subunit, two beta subunit. Here is the insulin molecule. Okay, so after it binds to the alpha subunit, there is some conformational change, which activate the tyrosine kinase, and some mechanism occurs inside the cell. These are called insulin signal pathway. At the same time, okay, there is translocation of this GLUT4 containing vesicle towards the cell membrane. When this reaches here, it binds there, and then with the help of this GLUT4 transporter, glucose has entered into the cell. This is a very, very important concept you should have. So what is the clinical implication here? If there is no insulin, these things cannot occur. That means glucose cannot enter into the cell through GLUT4, and these GLUT4 transporter are the majority of the glucose transporter in our body. That's why we suffer from effect of hyperglycemia all the time, and this is called diabetes. Let's talk about what is the normal glucose and fat metabolism because of the effect of insulin. So please pay attention. In human being, blood glucose is tightly regulated by homeostatic mechanism and maintained within a narrow range. So what is the normal blood sugar level in us? Yes?
It is 75 milligrams.
60
Okay.
to 120, sir.
Okay.
60 to 100.
Okay. Now see there, different answers are coming, and all of you are somewhere right there. Okay, so it differs. There is a huge range actually. It depends whether we do it in the fasting or the postprandial, okay, or a random blood sugar. But remember that rather than answering like this, it is better if you answer anytime it should not cross, okay, 126 milligram per deciliter as the fasting one, and the postprandial it should not cross more than 200. So it should be lower than that value. That is the uppermost range I'm providing you. But if you roughly say 80 to 100, okay, or 80 to 110, you are right there. Okay, any of the teacher will accept your answer. A continuous supply of glucose is essential for the brain, which cannot oxidize free fatty acid and relies upon glucose as its principal metabolic fuel. We all know that brain prefers glucose, but in case of crisis situation, ketone bodies also can be utilized by the brain. But that is a uh, not the preferable energy source for the brain. It always prefers glucose as the first choice. If that is not available, then ketone bodies can be utilized. When intestinal glucose absorption, okay, when intestinal glucose absorption decline between the meal, what happens? Now see there, all of you. Okay, please mute yourself. So let me underline, these are the important points for you. So when intestinal glucose absorption decline between the meal, hepatic glucose output is increased in response to low insulin level. And increased level of the counter-regulatory hormones like glucagon, adrenaline, okay, they are increased. Now, let me explain this in a very easy way. When our blood sugar level decreases, then the counter-regulatory hormones will become increased as the result of hypoglycemia. And then they try to bring that glucose back towards the normal. But when we eat, okay, when we have meal, after some time, the glucose is absorbed from our intestine. So that glucose will lead to hyperglycemia. That hyperglycemia will cause insulin release, the mechanism we have just studied. And that insulin will cause entry of glucose inside the cell, which leads to decreased level of glucose in the blood. So this is the main point here. And along with this, there are certain other things going on. For example, if glucose is excessive, it will be converted into glycogen and is stored in the liver and the muscle. And when glucose is less, that storage form will be broken down to, convert into glucose again. Okay, so these processes are known as glycogenesis and glycogenolysis. And one more process is also there, which is known as gluconeogenesis. This is known as new glucose formation. Okay, so insulin should block that new glucose formation pathway, because insulin will not allow the glucose to be increased in the blood, whereas insulin should promote glycogenesis and it should inhibit glycogenolysis. I'm sure you are getting the point here. Okay, so when we move to the next slide, we'll talk everything regarding them. Now see this, insulin is an anabolic hormone. What do you mean by anabolic hormone? Anabolism means what?
Formation formation of different substances.
Very good. Formation or synthesis. It's a synthesizing hormone. It's a synthesizing hormone. Exactly, exactly. So it has got a profound effect on the metabolism of carbohydrate, fat, and the protein. And when we have excessive insulin in our body, because of formation of all these substances, remember, the patient or the person will gain weight. The person will gain weight. And this is such an important concept, because when we talk about certain medicine we use for the treatment of diabetes, like sulfonylurea, those sulfonylurea leads to secretion of insulin. And when insulin is excessive there, the person will gain weight. This is the anabolic effect of the insulin. Anabolic effect of the insulin. Now let's move on. Insulin is secreted from pancreatic beta cell into the portal circulation with a brisk increase in response to a rise in blood glucose. So glucose is the most important, stimulation for insulin release. Even protein can lead to insulin release sometimes, even protein. But glucose is always the best one. And fat doesn't usually lead to insulin release. That's why if you want to lose weight, these days people are talking about keto diet. Keto diet means you should cut off carbohydrate in a significant amount in your diet so that there will be no release of insulin. And without insulin, you don't gain weight. So that is the concept. So everything is matching there. Let's move on. Insulin lowers blood glucose by suppressing hepatic glucose production and stimulating the glucose uptake in the skeletal muscle and the fat, mediated by glucose transporter known as GLUT4. Now see this. Okay, you should understand this very well. Insulin lowers blood glucose by suppressing hepatic glucose production. Now there are two ways of hepatic glucose production. What are those two ways? Yes, what are those two ways?
Glycogenolysis.
Gluconeogenesis.
Excellent, excellent.
Glycogenolysis.
Excellent. Very, very good. All the students are answering correctly. This is glycogenolysis and gluconeogenesis. So those two processes are suppressed or inhibited by insulin. Okay, that is a very well-known fact. Whereas it stimulates the glucose uptake in the skeletal muscle and the fat through GLUT4 transporter. And this is how our blood sugar level will be decreased, because sugar or glucose is entering into the cells. Let's move on. Now, all of this concept is, provided again by this, slide. Now, see this? To understand this, okay, you need to see here, the plus sign means stimulation and the minus sign means suppression by the insulin. So let's quickly go through it. See there in the liver, what is happening? The gluconeogenesis is suppressed by insulin. Look at the minus sign, suppressed. Okay, see this? Whereas the conversion of glucose into glycogen, that is called glycogenesis, is stimulated by insulin. So this is every student know by now. So this glucose, okay, is converted into different types of fat. Glucose is converted into fat. This process is stimulated by insulin. This is called fatty beta oxidation. Okay. So glucose will be converted into different types of fat. That's why these days people say the different doctors or different scientists, they are doing researches all the time in this field, and they have come to the conclusion that it's a carbohydrate which makes us fat. So we should cut down the intake of carbohydrate, because carbohydrate is the source of glucose. And whenever there is glucose, there is a role of insulin. And this insulin is the anabolic hormone. So the person will have a lot of fat deposition in different parts of the body. Okay. Now, let's come out of the liver and enter into the muscle. What is happening in the muscle? See this? The glucose is here. Okay. So glucose will be converted into glycogen, that is stimulated by insulin. Okay. And the oxidation is again stimulated by insulin, whereas the proteolysis is inhibited by insulin. Proteolysis is the opposite of anabolic effect. We know insulin is the anabolic hormone. So proteolysis is breakdown of the protein, that is inhibited by insulin. It stimulate the protein synthesis. What happens to the fat or adipose tissue? So see this, okay? The oxidation of the free fatty acid and formation of bigger molecules of the fat is stimulated by insulin. So triglyceride synthesis is stimulated by insulin, whereas lipolysis is blocked by insulin. So insulin doesn't allow lipolysis to occur. It rather causes synthesis of triglyceride. This is the important thing. Now, this free fatty acid and glycerol, okay, they are the components of the free fatty acid. This free fatty acid will be uptaken by the liver, and this free fatty acid will be converted into ketone body, okay, into ketone body. There are three types of ketone body we have. Can you name them? What are the three types of ketone body?
Acetoacetate, acetone, hydroxybutyrate.
Okay, okay, good. So they are acetoacetate, beta hydroxybutyrate, and acetone. We'll talk about them so many times in this class. Don't worry, okay? So the name will be highlighted later also. So these ketone bodies are synthesized by our liver. But what is the stimulation to synthesize this ketone body? You need to understand it right now. So please focus. Whenever we have this availability of free fatty acid by breaking down fat, then only these ketone bodies are synthesized. So when there is insulin deficiency state, then only this can happen, because insulin will inhibit lipolysis. So insulin should not be there. Then only this free fatty acid can be found in the blood, and this free fatty acid will be converted into ketone body. Okay, that's why in type 1 diabetes, which is absolute deficiency of insulin, there is high chance of formation of ketone body, and that is known as diabetic ketoacidosis. So these are the different concepts which are provided here. Let's move on. Now, let's talk about the normal glucose and fat metabolism further. So we are actually talking about that part only. So let's move further. Adipocyte are the fatty cells, and the liver synthesizes triglyceride from non-esterified free fatty acid and glycerol. This is known as lipid synthesis, okay, or triglyceride synthesis. Insulin is stimulating fatty acid or triglyceride synthesis. Insulin stimulates lipogenesis and inhibit lipolysis. So it prevents fat catabolism. Many times we have repeated this, so I'm sure students are quite confident now. Now, what is the mechanism here? Lipolysis is mainly mediated by triglyceride lipase, which is also known as hormone-sensitive lipase. It is stimulated by catecholamine, and after it is stimulated, it will break down the triglyceride and liberate free fatty acid. This free fatty acid can be oxidized by many tissues for the sake of energy production. Okay. Now, what is the effect of insulin regarding this? The partial oxidation in the liver provides energy to drive the gluconeogenesis and also produces ketone body like acetoacetate, beta hydroxybutyrate, or acetone. These are the three important types of ketone body we have. Among them, beta hydroxybutyrate is mainly present in the blood. Okay, small important point here. Acetoacetate is excreted in the urine, and acetone is a gas. Okay, it is mainly exhaled outside from our lung. So these are interchangeable substance. They can convert from one to other, which are generated in hepatocyte mitochondria. So liver is the site where ketone bodies are synthesized. And what is the source of these ketone body? What is the parent substance? That is free fatty acid. And free fatty acid is obtained from lipid or the triglyceride. And the triglyceride should be broken down by hormone sensitive lipase. And insulin, okay, will always suppress that enzyme. Remember, insulin will suppress that enzyme so that this mechanism will not occur. When there is a lack of insulin, then only this mechanism will take place. Let's move further. Ketogenesis is therefore enhanced by insulin deficiency and release of the counter-regulated hormone that stimulate lipolysis. What is the meaning? The conclusion of this discussion till now. Ketogenesis is inhibited by insulin. So it occurs only in insulin deficiency. That's the first thing. Whereas if ketone bodies are actively formed, that means the counter-regulatory hormone are there in excessive level. And those counter-regulatory hormones are catecholamine, okay, glucocorticoids, growth hormone, and glucagon. Catecholamine, glucocorticoid, growth hormone, and glucagon. Among them, the catecholamine are the very important one regarding this process. Let's move on. Now, to summarize, all the effect, what are the anabolic effect and what are the anti-catabolic effect of the insulin? Let's follow this table. These are the anabolic effect, or all of these are increased or stimulated by insulin. So regarding the carbohydrate metabolism, the glucose transport inside the muscle and adipose tissue is stimulated by insulin, or this is increased by insulin. Every student know this by now. Glucose phosphorylation inside the cell is increased. This is a utilization of the glucose. Okay. Glycogenesis is stimulated or increased by insulin. Glycolysis, okay, again the production of energy inside the cell is stimulated by insulin. Pyruvate dehydrogenase activity, this is an important enzyme in the beginning of a Krebs cycle. And pentose phosphate shunt or HMP shunt is also stimulated by insulin. So these are the important points. So please mute yourself. Yes. Okay. What about the lipid metabolism now? Triglyceride synthesis is stimulated by insulin. Fatty acid synthesis is stimulated by insulin. And lipoprotein lipase activity in the adipose tissue is increased by insulin. Okay. Whereas, see this, lipolysis is decreased by insulin. Lipoprotein lipase in the muscle is decreased. Ketogenesis is decreased or blocked. and fatty acid oxidation in the liver is blocked by insulin. So these are known as anti-catabolic effect. This is well known. Gluconeogenesis is always, inhibited, and glycogenolysis is also inhibited by insulin. Regarding the protein metabolism, amino acid transport is stimulated inside the cell so that more protein synthesis, which is an anabolic effect, which is written here, and protein degradation is inhibited by insulin. So this is a concept. Please repeat this. Sometimes it is a little bit confusing in the beginning. So I need to have more repetition and revision here. Okay, so let's move further. Now with this, let's talk about what is the etiology and pathogenesis of diabetes. We are entering into the topic proper now. Now, regarding the etiology and pathogenesis of diabetes, we need to know certain things first. Regarding the primary diabetes, okay, we have got two types, type 1 and type 2. Type 1 diabetes is also known as IDDM, and type 2 diabetes is known as NIDDM. Now, IDDM is a good term here. Okay, there is no confusion. This is insulin dependent diabetes mellitus. There is absolute deficiency of insulin in this condition, and without insulin, this patient is going to die. So treatment is insulin in this case. Whereas this NIDDM is a misnomer. Now, can anybody tell me why it is a misnomer? Why it is not a good term for type 2 diabetes? Non-insulin dependent. Yes?
Sir, because in the later stage, sir, the deficiency of insulin occurs, sir, in type 2.
Good. That is a very good answer you have given. Good. And that is the reason actually. Remember, in NIDDM, non-insulin dependent diabetes mellitus or type 2 diabetes also, we need insulin. Okay. When the person is having severe symptom, insulin is necessary for the treatment. So how can we say this is non-insulin dependent diabetes mellitus? That's why it is not a good term to use here. The better terms are type 1 and type 2 diabetes. In both of the common types of diabetes, the environmental factors, they interact with genetic susceptibility to determine which people develop the clinical syndrome and the timing of its onset. So there are two factors which combine with each other, and they are genetic susceptibility and environmental factors to cause a diabetes. Now, these are the primary diabetes. Now, what are the secondary diabetes? Because of some disease in the body, there is a damage to the pancreas gland, or to be very precise, islet of Langerhans or beta cells. So these are the causes of secondary diabetes. Very important question from the exam point of view. Let's elaborate a little bit on it. Pancreatic disease are the first one, like cystic fibrosis. Though cystic fibrosis mainly damages the exocrine part of the pancreas, over the process, even the islet of Langerhans can be damaged. Whole pancreas gland can be damaged. So we all know what is cystic fibrosis. This is the problem of exocrine gland mainly. In this condition, there is very thick type of secretion occurs. That thick type of secretion will block the duct, and then the secondary changes or the reaction occur, and the whole gland may not be functional after some time. This is cystic fibrosis. The diagnosis of cystic fibrosis is done by sweat chloride test. Sweat chloride test. Remember that there is excessive presence of sweat chloride in this condition. Now, chronic pancreatitis is another one. The main causes are alcohol and gallstone. Alcohol and gallstone. There are so many other causes. So chronic pancreatitis also can damage pancreas gland badly, can lead to secondary diabetes. Malnutrition related pancreatic disease, pancreatectomy, removal of the pancreas, hereditary hemochromatosis. This is genetic type of hemochromatosis or primary hemochromatosis, you can say. We have already talked about this. Iron can be deposited in different endocrine gland and it will damage those glands. This is the iron overload condition. Okay. So very easy to understand. And even the carcinoma of the pancreas can produce a similar type of effect. Now, among the endocrine diseases now, here, Cushing syndrome, acromegaly, thyrotoxicosis, pheochromocytoma, and glucagonoma. Now, just, think about all this for a moment. What is the common thing in all of them? There is one common thing in all of them. Okay, see there?
Sir, it's a counter regulatory mechanism, anti-insulin.
Thyrotoxicosis.
Yes, good.
Anti-insulin effect.
Very good. These are counter-regulatory hormone excessive activity. These all are anti-insulin condition. See this, Cushing syndrome is an excessive level of glucocorticoid in the body. Glucocorticoid is an anti-insulin hormone. Acromegaly, excessive growth hormone. Thyrotoxicosis, thyroid hormone also increases blood sugar level. Pheochromocytoma, excessive catecholamine, and glucagonoma, excessive glucagon. All of these leads to hyperglycemia, and hyperglycemia is the condition for diabetes. So that's why they are the causes for secondary diabetes. Very easy to understand. Okay. Now, the other one, drug-induced diseases like thiazide diuretic, corticosteroid therapy, atypical antipsychotic, antiretroviral protease inhibitor, and even beta blockers. All of these are connected with diabetes or hyperglycemia. So these are the drug which causes hyperglycemia. Atypical antipsychotic. Okay. Now those typical antipsychotic drug like chlorpromazine, haloperidol, they do not usually causes this type of side effect. The other types like clozapine, olanzapine, isn't it? Risperidone. These are the antipsychotic drug which are called atypical one. So they may cause hyperglycemia. Other things are quite easy for you. Now, insulin receptor abnormality is the another cause. And in this heading, we have congenital lipodystrophy and acanthosis nigricans. Now, this is a lipodystrophy. Probably these lipid cells or lipid tissues are not responsive to insulin. So if they are not responsive to insulin, glucose cannot enter into the fat cells, resulting in hyperglycemia. Okay, I understand like this. Whereas acanthosis nigricans is the acquired type of mechanism. This is also known as syndrome of insulin resistance. Syndrome of insulin resistance. In this situation, there is black velvety appearance on the skin, especially around the axillary region. These are sometimes associated with bronchogenic carcinoma also. So we can consider them as a paraneoplastic syndrome sometimes. Okay, the person is usually obese and the person has insulin resistance problem. Now, some genetic syndrome also leads to secondary diabetes, which are Friedreich's ataxia and dystrophia myotonica. Okay, ataxia is unable to walk on a straight line. So you already know some balance mechanism is altered here, mainly the cerebellar function, and along with that, it also damages our heart. Okay, dystrophia myotonica is the problem of the muscle. These are a rare condition. Now with this, let's enter into the pathology of type 1 diabetes. What is happening here? Type 1 diabetes. Now, please pay attention. You need to understand this before we move further. This topic is very important and a big one, okay? And these are the basic things. Type 1 diabetes is a T-cell mediated autoimmune disease. And that's why we always take this type 1 diabetes as one of the example of autoimmune diseases in our body. All the time, if your teacher asks, can you tell me some of the autoimmune conditions in our body? Without hesitation, take example, type 1 diabetes. Okay, just one of them. It involves destruction of the insulin secreting beta cell in the pancreatic islet. So there is destruction of beta cell so that there will be no release of the insulin. Insulin is absolutely absent here. Hyperglycemia accompanied by the classical symptoms of diabetes occurs only when 70 to 90% of the beta cells have been destroyed. And that's what happens in type 1 diabetes. The pathology regarding this, okay, is insulitis in the beginning. Now, see there, insulitis, okay, is the infiltration of the islet with mononuclear cell containing activated macrophages, cytotoxic and suppressor T lymphocyte, natural killer cell, and B lymphocyte. So if you analyze, all of them are mononucleated cell. They have only one nucleus. That's why they are called mononuclear cell. And they are the chronic inflammatory cell. See here, macrophages, lymphocytes, okay, and NK cell, all of these. So in the beginning, there is insulitis. It's damage of the beta cells of the islet of Langerhans. Now, another important point here, there is a genetic predisposition, and that accounts for about, okay, that accounts for about one third of the susceptibility to type 1 diabetes. And the inheritance is usually polygenic. Multiple factors are there. And when they analyze, HLA-DR3 and HLA-DR4 are associated with increased susceptibility to type 1 diabetes. So there is a role of genetic susceptibility or genetic predisposition as well. But only this may not cause type 1 diabetes. There has to be interaction between this susceptibility and the role of autoimmunity. Now, let's combine all of these things which we have discussed till now in the pathogenesis of type 1 diabetes. So this is a proposed sequence of event in the development of type 1 diabetes. What happens in the beginning and what happens at the end. This is a normal islet of Langerhans, and these are the beta cells which are present here. Okay, the person is already genetically susceptible already, because this is a matter of gene, isn't it? The person is already carrying those gene. See this, genetic susceptibility to immune dysfunction. Now, on top of that, there is an environmental trigger, okay? The effect of environmental agent, like maybe some viral infection, okay? The Coxsackie virus is one of the virus which is implicated here. Along with that, some others are also there. Okay. Now, there is a activation of autoimmunity. That autoimmunity will result in infiltration by different mononuclear cell, which is known as insulitis. Insulitis. So what happens in insulitis? There is inflammatory cell infiltration of islet of Langerhans. The antibody are also synthesized. They mediated beta cell destruction, and autoantibodies are present in the blood. These are called anti-islet cell antibody. So this antibody, when B cells are stimulated, they convert into plasma cell, and then these antibodies are going to be synthesized. Now, ultimately, because of the interaction of all these things, there is severe damage of the beta cell, and they are destroyed. So there will be no release of insulin, and this is the overt diabetes. Overt means with sign and symptom. This is a clinical diabetes. Okay, so this is the thing. In the beginning, probably there is impaired glucose tolerance, and later on, that condition will convert into frank or overt diabetes. Now, one small question for you. What is impaired glucose tolerance? Anyone? What do you mean by that?
Sir, when the glucose level in between the fasting glucose and the postprandial, so we call it glucose intolerance.
Okay, yes, that is a one of the good way of answering. Impaired glucose tolerance means the person has not developed frank diabetes till now, but the glucose level is also not normal according to the normal standard. So it is in between process. That means the person is going towards diabetes. So what we suggest, good exercise and the control in taking the meal. These are the two things which we'll suggest in case of impaired glucose tolerance. We don't start treatment here, but we monitor the cases frequently. So at any time the person may, develop the frank state of diabetes. Let's move on. Now, okay. Now, another part here, what are those environmental factors? We have been talking about these environmental factors and things like that, but what are those actually? Do we know them or not? Okay, so let's talk about it. The environmental factors have an important role in promoting the clinical expression of the disease. So let me clarify once again here. The person is already having those affected gene. The person is already having genetic susceptibility. On top of that, if these environmental factors are present, then only there is a chance of destruction of beta cell. We should always understand like this. One proposal is that the reduced exposure to the microorganism in early childhood limit the maturation of the immune system and increases the susceptibility to the autoimmune disease. This is known as hygiene hypothesis. This is a very interesting type of concept, and this is such an important point to understand. Okay, so let me clarify it. Now, if our babies are not exposed to outer world, okay, we always keep them inside the home. We don't allow them to play with their friends outside, in that situation or that environment. Then they will be never be exposed to those antigen there. And their antibody is not formed against those antigen. Okay. And later on, if they are exposed, when they are a bit of big boy or girl now, or adult also, if they are exposed to that environment, they cannot cope with that environment. They will be, suffering from signs and symptoms of this condition very quickly. This is known as hygiene hypothesis. And that's why, the children from the developing world, they have better immunity in comparison to the children who are from the developed country. Now, if they go to the, some sort of situation like this, where there is a lot of microorganism in the environment, they quickly become sick. And this is one of the very important concept of hygiene hypothesis. Okay. Now, another is that the viral infection in the pancreas alters the beta cells immunogenicity, and several viruses have been implicated here, including mumps, Coxsackie-B4 virus, retrovirus, rubella, which may attack inside the uterus, cytomegalovirus, and Epstein-Barr virus. But among them, the important one from the exam point of view are mumps and Coxsackie-B4 viruses. Okay, so they may, directly damage or change the immunogenicity of the beta cell. Let me finish this and then we are going to take a break. Now, see this? Some other pathogenetic steps of type 1 diabetes. Stress may play a important role. So this stress may precipitate type 1 diabetes by stimulating the secretion of counter-regulatory hormone and possibly by modulating the immune activity. The more important one is this first one. It stimulates the secretion of counter-regulatory hormone. Remember, a stressful condition, glucocorticoid is released, catecholamines are released. So they cause hyperglycemia, and that simply precipitate the type 1 diabetes process. Dietary factor may also be important in this regard. Various nitrosamine, which are found in smoked and cured meat, and we call them processed meat, okay, processed meat, and even the coffee have been proposed as a potentially diabetogenic toxin. This is a hypothesized thing, okay, but we should be serious regarding them. And bovine serum albumin, a major constituent of the cow's milk, has been implicated, since children who are given cow's milk early in infancy are more likely to develop type 1 diabetes than those who are breastfed. So this is another reason, for the continuation of breastfeed or exclusive breastfeeding. But Let me repeat again. These are the different hypotheses. All of the babies may not have this risk factor when we take the history. Okay, let's do this and then we are going for a break. Now see this, all of you please focus here. This is absolutely important slide. I will repeat it later on also, but at this juncture, this is very relevant for us to discuss. This is the pathophysiological basis of the symptom and sign of uncontrolled diabetes mellitus, especially type 1, but type 2 is also included here. See this, there is a lack of insulin. What is the definition of diabetes? I want to hear it again from you. What is the definition of diabetes? Anyone?
So there is hyperglycemia that
The
because of
glucose
the
level in the
absolute
blood is
or relative deficiency of
Fasting blood
and
sugar greater than 120.
Good. So different types of answers are coming. Okay, very nice. So you can answer like this. Diabetes mellitus is a syndrome where there is absolute or relative deficiency of insulin, and that should be added by those level, if you remember. When fasting, blood sugar crosses more than 126 milligram per deciliter, and when postprandial crosses for more than 200, along with sign and symptom, this is known as diabetes. That is an excellent definition. Now let's come to the slide here. So there's lack of insulin. So because of this, there is decreased anabolism. There is increased secretion of counter-regulatory hormone. Look at the name: glucagon, cortisol, growth hormone, and catecholamine. And there is increased catabolism. Now, increased catabolism means glycogenolysis is increased, gluconeogenesis is increased, and lipolysis is increased, okay, which results in formation of ketone body. Hyperketonemia is ketone body, excessive ketone body in the blood. Okay, now those ketone bodies are the keto acid. Okay, they are the keto acid, so they will cause metabolic acidosis. There are other causes of metabolic acidosis also here, and that is by dehydration. Dehydration occurs in type 1 diabetes. Okay, and because of that dehydration, there is hypovolemia. Hypovolemia can lead to acidotic environment. This acidosis will lead to hyperventilation, okay, and peripheral vasodilation. So hypotension and hypothermia can occur in this condition because vasodilation will lead to loss of heat, that is hypothermia, okay, and because of vasodilation, hypotension can also happen. Hypotension is also contributed by dehydration or hypovolemia. Now, this state is called diabetic ketoacidosis. It can lead to death because of cerebral edema and a lot of other complications. Let's go to the other side. There is decreased anabolism, okay, means there is hyperglycemia. Glucose cannot be utilized, remember that. So there is hyperglycemia. Glycosuria, excessive glucose secretion, okay, or excretion in the urine. This glucose will also carry water along with it, which leads to osmotic diuresis. Now, look at the important clinical feature because of this problem. Hyperglycemia can lead to fatigue. Glycosuria can lead to vulvitis and balanitis. These are the infection there. Usually fungal infections are quite common in the presence of glucose. Osmotic diuresis can lead to polyuria and polydipsia. Okay, polyuria because of excessive urine formation, and polydipsia when the person becomes thirsty, okay, and he or she drinks more water, that is polydipsia. So what happens ultimately? There is hypovolemia because of severe dehydration, which leads to tachycardia and hypotension. If this is not treated in time, the person can die. So this is a very good correlation or connection, okay, between the different event, especially in case of type 1 diabetes. Okay. Now, regarding the pathology of type 2 diabetes, let's talk about it. Type 2 diabetes is a more complex type of condition than type 1 because of a combination of resistance to the action of insulin in the liver as well as in the peripheral tissues, and along with that, there is an impaired pancreatic beta cell function leading to relative insulin deficiency. Now, let me clarify this. In type 2 diabetes, there are two main problems. One, insulin resistance to the peripheral receptors. They are probably not accepting insulin there. Second, there is problem in the release of insulin also, okay, from the beta cell. Usually there is decreased release of insulin from the beta cell, but sometimes, it is very interesting to know, sometimes the amount of insulin which is released by beta cell is even more than necessary. But in that condition, the problem is insulin resistance is far more than we expect. So two things: relative, decrease in insulin release from the beta cell, and resistance for the insulin action in the peripheral tissues. This is known as type 2 diabetes. Insulin resistance appears to come first and leads to elevated insulin secretion in order to maintain the normal blood glucose level. Just like a compensatory mechanism, isn't it? If insulin cannot act, then the beta cells thinks, yes, I need to release more insulin. So that happens in the beginning. However, the pancreatic beta cells are unable to sustain the increased demand for insulin, and slowly they develop a progressive insulin deficiency. It's a bit like a heart failure. Remember, we can compare this condition with the heart failure. What happens in the beginning? The heart can try to cope up with the situation of increased demand, but it cannot do it forever. Okay, it cannot do it forever. It's like a Frank Starling law, and sometimes later the heart fails. So same condition. In the beginning, the beta cells try to secrete more insulin, but later on that cannot happen. So insulin deficiency develops. Let's move on. Okay, please mute yourself, guys. Wait. Okay, mute all of them. Yes. Okay. Now, regarding the pathogenesis of insulin resistance, okay, let us discuss. The type 2 diabetes and impaired glucose tolerance are often associated with other disorders like central or visceral obesity, hypertension, and dyslipidemia. This dyslipidemia means there is elevated levels of low density lipoproteins, cholesterol, and triglyceride, and a low level of high density lipoprotein. So let me, explain this in other way. Sometimes what happens, the person doesn't look very fat or obese. The person is carrying excessive deposition of fat in the inner parts of the body, like around the tummy, around the waist area. This is known as visceral obesity. This visceral obesity is responsible for development of insulin resistance, and that same patient may be having dyslipidemia, okay, excessive level of bad type of lipid and low level of good type of lipid. So this is the meaning. The primary cause of insulin resistance remains unclear, though intra-abdominal or central adipose tissue is, highly suspected for this mechanism because it is metabolically active and it releases large quantities of free fatty acid, which may induce insulin resistance in this situation. So what is happening here? The fat which is present around the waist area, inside our tummy or belly area, is highly active metabolically. So a lot of free fatty acids are released from there, and that free fatty acid is inducing insulin resistance in the peripheral tissue. So this is one of the important mechanisms. Let's move on. Now, let's talk about what do you mean by metabolic syndrome. I'm sure some of the students have already heard this term before, which is metabolic syndrome, and these are the different components. Metabolic syndrome is the state of insulin resistance. So this patient is having hyperinsulinemia. Now see this, the insulin level is increased than the normal. So hyperinsulinemia is there. So still, why the person is diabetic, even if the insulin level is high? Because of the resistance. The insulin cannot act properly. The person is having type 2 diabetes or impaired glucose tolerance. The person may be hypertensive. There is low HDL cholesterol and elevated triglyceride. The person is having visceral obesity or central obesity or fat deposition around the waist area or inside the abdomen. There may be affection of the kidney, which is known as microalbuminuria. Microalbuminuria. This is one of the condition of renal affection in case of diabetes. There may be increased level of fibrinogen. Okay, increased level of fibrinogen. Fibrinogen is a type of clotting factors. There may be increased plasminogen activator inhibitor 1. There may be increased C-reactive protein, and there may be elevated plasma uric acid. All of these may not be present in the single patient. Always remember this. But if these important factors are present, then we call it metabolic syndrome. This metabolic syndrome is a very important state for insulin resistance or type 2 diabetes. Let's move on. Now, what is the role of physical activity, okay, in the pathogenesis of type 2 diabetes? Physical activity is a very important determinant of insulin sensitivity. Now, one of the important point here, if we actively do physical exercise, then during that time, the entry for glucose inside the cell is independent of insulin. It doesn't need insulin to enter glucose into the cell. So this is a very important point, isn't it? That's why we often advise physical activity for the diabetic patient. So inactivity is associated with down regulation of insulin sensitive kinase and may promote the accumulation of free fatty acid within the skeletal muscle. So opposite things will happen. So physical activity is really important if somebody doesn't want to develop a diabetic condition or state. And then inactivity is helping for the development of diabetogenic state. Remember like that. Moreover, physical activity allows non-insulin dependent glucose uptake into the muscle. That's what I discussed just now. Now, what's the role of genetic predisposition regarding type 2 diabetes? Let's talk about it. Genetic factors are important even in type 2 diabetes, as shown by marked differences in the susceptibility in different ethnic group and by studies in monozygotic twin, where the concordance rate for type 2 diabetes approaches near to 100%. So there is a clear-cut role of the gene here, and that is proven by the study in the monozygotic twin. If one of the twin develops diabetes, that is type 2, another has a 100% chance of developing it. This is known as concordance rate. Okay, so we know there is a genetic predisposition. Most of the genes which are known to contribute to the risk of type 2 diabetes are involved with beta cell function or in regulation of cell cycling and turnover. So either beta cell is not secreting enough insulin, okay, or there is a problem in insulin receptor. Let's move on. Now, what about the diet and obesity? What is the role of this in type 2 diabetes? Now, let's talk about it. Now, this type 2 diabetes is associated with overeating, especially when combined with obesity and underactivity. We all know obese patient or obese person has high chance of development of type 2 diabetes. You have been hearing this from a long time, and this is the connection between them. So these obese people, they overeat all the time, and they are relatively underactive also. They don't want to indulge themselves in physical activity. All of these things combined together and leads to type 2 diabetes. The risk of developing type 2 diabetes increases significantly, that is more than 10-fold in people with a body mass index of more than 30. So what is the definition of obesity according to the body mass index? Yes. What is the definition?
BMR is
More
BMR
than
is big.
30. BMI is more than 30.
More than 30
Exactly.
kg
Exactly.
per
See this. BMI more than 30 is called obesity. Okay. BMI more than 40 is morbid obesity. Okay. It's altogether a very different thing. So this is the point here. So there is a 10-fold increased chance if the person is, obese for the development of type 2 diabetes. However, although the majority of patients with type 2 diabetes are obese, only a minority of obese people develop diabetes. Obesity probably acts as a diabetogenic factor, and that is mainly done by increasing the resistance to the action of insulin only in those who are genetically predisposed both to insulin resistance and the beta cell failure. Okay, so let me clarify this, a little bit confusing statement for you. Please listen properly. This is an important concept here. Let's take 100 obese cases. Okay, 100 obese cases and follow them up. All of them will not develop type 2 diabetes. All of them will not. Those people only develop type 2 diabetes who are genetically predisposed first. And on top of that, if they are obese, okay, then only they develop type 2 diabetes. So 100% of the obese people are never developing type 2 diabetes. Okay, there is a strong role of genetical susceptibility as well. Let's move on.
Sir, I have one question.
Yes, yes, sure.
Sir, according to this slide, sir, only the obese patient develop type 2 or the lean patient also develops diabetes?
Very good question. Okay, Mujib. Even lean patient develops type 2 diabetes because the fat may deposit around the waist area. Okay, and that visceral fat is very important for the causation of insulin resistance. So the person still looks lean and thin. Remember that he may have slight tummy only, but overall appearance is still leaner and thinner. But still, that person can develop type 2 diabetes. We already talked about that. That is known as metabolic syndrome, right? So here we are mainly concerning on this body mass index when it is more than 30. Means it is a really obese looking patient or overweight looking patient. We are talking about them now. Okay, let's move on. What is the role of age now in type 2 diabetes? See here. Type 2 diabetes is more common in the middle aged and elderly population. Over 70% of all cases of diabetes occur after the age of 50. But sometimes they can also occur in children or adolescent or really young people also. But more common are the middle-aged and elderly people regarding type 2 diabetes. Whereas in type 1 diabetes usually occurs during childhood. Now, what is the effect of pregnancy regarding a pregnancy regarding the type 2 diabetes? You have already studied this in obstetrics. During normal pregnancy, insulin sensitivity is reduced through the action of placental hormone, and this affects the glucose tolerance. So which hormone is important regarding this effect? Which hormone? Can you name it? Which placental hormone? Anyone?
HPL.
HPL.
Human
Very
growth
good.
HP.
HPL. I already got the answer here. Human placental lactose, HPL, is the one which is mainly related with insulin resistance. Okay, in this case, The term gestational diabetes refers to the hyperglycemia occurring for the first time during pregnancy, and the repeated pregnancy increases the likelihood of developing irreversible diabetes, particularly in obese women. So let me clarify this, though yeah, I'm sure you have already done this in obstetrics. There are two types of diabetes during the pregnancy. One is called gestational diabetes, which develops for the first time during pregnancy itself. Another is called chronic diabetes. The lady is diabetic from the beginning. Then that diabetes can just increase during the pregnancy because of different hormonal effect, like HPL. Okay, and the pregnancy outcome also differs according to which type of diabetes is it. In gestational diabetes, uh, uh, the baby may become big baby, okay, macroscopic baby, whereas because of the chronic diabetes, there may be some complication development already. So there is a chance of IUGR baby or small for gestational baby delivery in case of chronic diabetes. So don't forget, these are the important questions which will be asked to you in your future exam. Let's move on. Now, all of you, please focus on this slide. Okay, what information you get here. See this. This is called natural history of type 2 diabetes. Here is the normal. Okay, now see this. This is the plasma glucose, this red line, and this blue one is the plasma insulin. Now, this is normal, means, the plasma glucose is well controlled by plasma insulin. That's the meaning. And here, there is hyperinsulinemia. Hyperinsulinemia. The beta cells is secreting more amount of insulin, and that increased amount of insulin is controlling the blood sugar level. So euglycemia is there. Now later on, the insulin resistance has developed because of so many different factors which we just discussed. Maybe the genetic susceptibility, okay, maybe the like type 2 diabetes is because of obesity, isn't it? Acanthosis nigricans and different type of thing. So in the beginning, there is impaired glucose tolerance. Even if there is a high level of insulin, now the glucose start to rise slowly because of the insulin resistance. And ultimately, okay, the insulin cannot be secreted at an increased rate all the time by beta cell. So insulin level also falls, and naturally when insulin falls and there is excessive resistance of the insulin at the receptor level, the plasma glucose rises. Okay, so this is the another graph which is telling the same thing. So here we have diagnosed and we have started the treatment of type 2 diabetes. See this. Now over a period of time, the beta cell functions gradually deteriorate, and ultimately it is not secreting the same amount of insulin. And this is known as relative deficiency of insulin later on. And then we may need to introduce insulin now. If insulin is not coming at all from the beta cell, we need insulin for the treatment, even if it is a type 2 diabetes. Now, at the end of this very important topic, before I enter into the second phase of diabetes discussion, let's compare between type 1 and type 2 diabetes. See there? Very important question from the exam point of view. Type 1 diabetes occurs mainly in the younger people, usually less than 30 years of age, whereas type 2 occurs mainly in the older one. The persons are usually lean and thin in type 1 diabetes. There is absolute deficiency of insulin, and insulin is an anabolic hormone. So without that anabolic effect of the insulin, the person looks very lean and thin. This is a very good reason, and it is very easy for you to remember also. And they are often overweight. Type 2 diabetic people are often overweight. Now, what may be the reason for that? I can give two important reasons here. One, in the beginning, there is over secretion of insulin from the beta cell, that insulin is causing weight gain. And another one, obesity itself is a risk factor for type 2 diabetes. Okay, they are already overweight from the beginning. So both types of explanation are acceptable here. Regarding the race, this is not very important because these days any of the races are developing diabetes. And type 1 diabetes has a seasonal incidence because of the risk factors. Remember all those viruses there. So because of those viruses, it is written like that, seasonal incidence. Regarding the hereditary, HLA-DR3 or DR4 is present in more than 90% of the cases, and there is 30 to 50% concordance rate in identical twin. In type 2, there is no HLA link, and there is more than 50% concordance rate in identical twin, or sometimes even 100%. Regarding the pathogenesis, this is autoimmune disease, that is type 1 diabetes. So there is presence of islet cell autoantibody, there is insulitis, there is association with other autoimmune diseases like vitiligo, myasthenia gravis, Addison's disease, Hashimoto's thyroiditis, pernicious anemia, or even Graves' disease. And one more thing, immunosuppression after diagnosis delays the beta cell destruction. All of these points are in favor of autoimmune mechanism for the destruction of beta cell. Whereas in type 2, there is no immune disturbance, but there is insulin resistance in the periphery. Regarding the clinical features, there is absolute deficiency of insulin. It may develop ketoacidosis if it is not controlled, and it always needs insulin for the treatment. Without insulin, I already told you, these people are going to die. Whereas in type 2, there is partial insulin deficiency, okay, may develop hyperosmolar state. This is not ketoacidosis. This is different than that. We'll talk about this during our complication part. And it may come to need insulin when beta cells fail over the time. Though the term is NIDDM, non-insulin dependent diabetes mellitus, that is a misnomer because of this reason. Because later on, those beta cells, okay, they fail to produce insulin, and the patient need insulin by that time. But in the beginning, they are still working, remember that. So we don't give insulin in the treatment of type 2 diabetes in the beginning. One very important another difference is C-peptide. See this? There is eventual disappearance of C-peptide. C-peptide is not found in type 1 diabetes, as there is absolute deficiency of insulin. Insulin is not secreted at all by the beta cell, whereas in type 2, C-peptide persists because beta cells are still functioning. So these are some of the important differences. We can add a few more later on when we do this topic. Okay. So with this,